Good evening, everyone, and welcome to Queen's Free Speaking of Health lecture series. Tonight's lecture is called Understanding Epilepsy, and it looks like we have a very nice, intimate crowd. So if you have questions, you can ask. You have a lot more time to ask it this time. Yay! My name is Lisa Sakia. I'm with Corporate Communications here at the Queen's Medical Center, and I welcome you this evening. Okay, and at this time, I'd like to introduce you to our main speaker this evening, Dr. Alan Stein, who is the Medical Director of Epilepsy and Neurophysiology at the Queen's Neuroscience Institute. Give you a little bit of background before he takes the podium. He went to the University of Wisconsin. He got a Bachelor's of Science in Medical Microbiology. He got his Doctor of Medicine at the Johns Hopkins University School of Medicine. He did his internship in internal medicine at the University of Maryland Medical Systems. He did his residency in neurology at the Johns Hopkins Hospital. He did a fellowship in epilepsy and clinical neurophysiology at the Barrow Neurologic Institute. He has a diplomate with a specialty of neurology, a specialty of neurophysiology, and a specialty of epilepsy with the American Board of Psychiatry and Neurology. He is an assistant clinical professor of neurology with the Department of Medicine at the John A. Burns School of Medicine. He is a past president and past treasurer of the Epilepsy Foundation of Hawaii and a past president and past treasurer of the Hawaii Neurologic Society. Please join me in welcoming Dr. Alan Stein.
Thank you very much, Lisa. Boy, I actually sound pretty impressive on paper, I guess. Thank you all for coming. Before we get started, I do want to let people know that there will be another series of lectures on Saturday, November 12th, right here in this exact same location, put on by the Epilepsy Foundation of Hawaii. There will be a number of lectures on a number of different topics regarding epilepsy. I myself won't be speaking, but my partner, Dr. Victoria Wong, will be speaking, as well as a number of other excellent speakers. So that'll be on November 12th, Saturday from 8:30 till 3:30 p.m. So with that, I will get started. My lecture will probably take about a half an hour, 40 minutes, and then we'll have time for some questions afterwards. If you ask questions, please be aware I can talk about epilepsy in general, but I probably can't give you specific medical advice about your particular case, since chances are I don't know your particular case. So the first thing I like to start out with is really talking about what is a seizure. I tell my patients it's like an electrical storm inside the brain. And it can either start in one spot in the brain and then possibly spread, but the key is that it might start in one spot, or there are other epilepsy types or seizure types that kind of come over the whole brain all at once. Another way of thinking about it is an imbalance between excitation and inhibition. That may not make a lot of sense, but probably the way that makes the most sense to me is to think of it as abnormal synchronous brainwave activity. So what do I mean by that? That may not make a lot of sense to you. Well, your brain is made up of billions and billions of brain cells called neurons. And they're all interconnected to each other, but they're all kind of doing their own thing at any given moment. And if you think about like being at a football stadium and wrong direction. If you think about like being at a football stadium and there's 50,000 people in the stands, and some of them are watching the football game, and some of them are looking at the cheerleaders, and some of them are trying to get the attention of the hot dog vendors, and a couple, some people are just talking amongst themselves. But they're all there for the same reason. They're there to for the football game, but they're all kind of doing their own thing. And then something may happen which gets large groups of people to actually start doing exactly the same thing in unison in a coordinated way. And so,
Carolina State. And now he's got the Badgers dreaming of playing for a BCS championship.
With the wave,
man, look at the
you've got
slow
large
motion wave.
groups of people in the audience that are all standing up in unison, sitting down in unison, and you might get multiple waves of the wave, so that happens over and over again. And a seizure is kind of like that, in that you've got a large group of cells, of brain cells, that start having electrical activity that synchronizes, all kind of firing at the same time. And normally that doesn't really happen. And so, again, it's kind of like a whole group of cells that are doing things coordinated in unison in a way that really isn't supposed to happen. I will point out probably the most important part about this little video clip I showed you, though, is the score. I want you to all notice the score. How do I get to my next thing? Okay, so that's what a seizure is. A seizure is like this electrical storm inside the brain. Well, what is epilepsy? Epilepsy is just a medical condition of having recurrent seizures. So a seizure, that electrical storm activity, really is a symptom of something being not quite right in the brain, okay? So by a symptom, think about like a cough. You could have a cough because you breathed in some dust, or you could have a cough because you have a lung tumor. They're two very different things, but they both would provoke a cough. So the cough is the symptom of something being wrong going on in your lungs, okay? So epilepsy is with the seizure, where the seizure is a symptom of something not being right in the brain. And epilepsy is this recurrent seizures that happen over and over again, okay? Now, it might be that you have seizures because you're diabetic and you took too much insulin and then you didn't eat dinner because you weren't feeling well and your blood sugar got really low and that caused the seizure. Even if that happens several times, we still don't call that epilepsy. Epilepsy refers to what we would call unprovoked seizures, meaning there isn't an obvious specific trigger that happened right at that moment. And there could be a very wide range. So seizures could be anyone who's had only a couple of seizures in their entire life, up to some of my patients who have many, many, many seizures every single day. And epilepsy is actually quite common. Most people may not realize this, but actually studies have shown that almost 1 out of 26 people, which is almost 4%, have been given a diagnosis of epilepsy at some point in their life. And that's a pretty big number. Now, at any given time, we think that about 1% of people have epilepsy, okay? So that would mean that I need to update this slide. The population in the U.S. is higher than it was when I made this. But in the U.S., now it would be somewhere around 3.5 million people with epilepsy, and in Hawaii, roughly about 15,000 people, which would correlate to a population of about 1.5 million people in the entire state. Now, about 2/3 of people with epilepsy have it pretty easily controlled, but there's about 1/3 where our medicines just don't get those seizures controlled very well. And so we say that they have medically intractable epilepsy or hard to control epilepsy. So here's kind of pictures of a bunch of people who actually have epilepsy. Upper left-hand corner, does anyone know who this guy is? I think I heard someone say. John Roberts, he's the Chief Justice of the Supreme Court of the United States of America. So he's done pretty well for himself. This guy down here, he used to be our governor. He's done pretty well for himself. This guy, you guys, I can never remember if that's Abbott or Costello. I think that's Bud Abbott. But he had epilepsy. And for the younger folks in the crowd, this is a rap artist named Lil Wayne. So I like to say epilepsy is not just for the rich and famous, but certainly there are some rich and famous people who have had epilepsy. Many people think that epilepsy just affects mentally retarded kids or only affects kids, but actually it can affect anybody at any age. So again, this is this rap star Lil Wayne, who at the time I put these slides together a couple of years ago had recently been in the hospital, and there was a lot of news stories about him, and he said, yeah, I have epilepsy. That wasn't the first time that happened to me. But most people don't know about that. Also at the time there was the head coach of the University of Minnesota had a seizure on the sidelines at a couple of games, and there was a lot of traffic on the internet, a lot of internet posts and things like that, talking about, oh, they should fire him and things like that. And so again, there's a lot of myths about epilepsy. There's sometimes discrimination against people with epilepsy, and so hopefully we can dispel some of those myths today. So as a doctor, how do I figure out if someone has epilepsy? Well, how does it start? Do people get a warning? What do people do during the seizure itself? If I ask the patient, they may not know what they do because they're kind of unconscious a lot of the time. But if I ask their spouse or their children or their parents, what did they do? Oh, they had a far off look in their eyes. It was like the lights were on, but nobody was home. And they smacked their lips and they did funny things with their hands or things like that. How long does it last? Seizures generally only last about 30 seconds to maybe 2 minutes. So if someone says, oh, he was like that for 4 hours, I'm starting to think, well, maybe that wasn't a seizure. Maybe that was something else. What are they like afterwards? Many times people with a seizure, after the seizure is over, they have what we call a postictal state where they're very confused or maybe they're very sleepy and hard to arouse. Post means after and ictal means seizure. So postictal just means after the seizure, and we call it a postictal state. Were there any specific triggers like flashing lights or staying up late and not getting enough sleep or things like that? Is there a family history? Because there are some hereditary forms of seizures that will run in families. Is there a history of brain injury? Did they have a really bad car accident and were in a coma for 3 days, maybe when they were, maybe 3 or 4 years ago? So these are all the things that I'm going to ask to try and figure out whether someone is really having seizures when they come to see me. Then we'll do some tests. So the most common test we do for epilepsy is what's called an EEG. And so you can see this picture of this kid over here, and he's got a bunch of wires that are glued to his head. And this down here, this tracing with a whole bunch of squiggly lines on it, each one of these lines actually represents the brainwave activity from one of these wires that's glued to the head. And so I'll look at the brainwaves and see if I can see evidence of seizures in some of these in the EEG. And then we'll also often do an MRI scan, which is much more sensitive than a CAT scan for picking up reasons for people to have seizures. So we'll look at the MRI scan and see if there's any reasons. Sometimes the reasons are very subtle on the MRI scan. So, I don't expect anyone, sitting out there to be able to notice this, but if you look at this particular part of the brain over here, it actually looks smaller than the same spot over on the other side. And in fact, this is a very common reason why people have seizures, is some scar tissue right in this particular part of the brain. So we do an MRI. We actually do it in a very special way where a regular brain MRI might not be looking at that particular area, but we're going to do MRIs and see if we can see a reason for someone to have seizures. So seizures get kind of classified into two main categories. One is primary generalized, where they start over the whole brain all at once. Those are often hereditary, versus partial seizures, which are much more common, where the seizure starts just in one spot in the brain. And maybe that was a part of the brain that was injured with a stroke or a brain tumor or an infection or a head injury. Or many times we can't figure out why the seizures are happening or where they're coming from, but and we don't see it on the MRI, but nonetheless, if we look at the EEG, we can see that there's abnormal brainwave activity coming from one particular spot. So again, looking at the EEG with some particular types of epilepsy, remember that each of these lines represents a different wire that's hooked up to the patient's head. And so I'll tell you that the first half of this EEG is normal, and then all of a sudden you start getting this very abnormal high volume brainwave activity. And if you look, it's kind of happening in every one of these lines, okay? So this isn't a focal seizure. This is one that kind of is going over all the brain all at once, and this would be what we would call a primary generalized seizure. And there are multiple different types of primary generalized seizures. Kids often get a type called absent seizures. It also used to be called petit mal seizures, and they might just have a blank staring spell. A myoclonic seizure means like a little muscle jerk. Tonic-clonic is what most people think of as a grand mal seizure. Tonic means stiff, and clonic means jerking. So a tonic-clonic seizure, people get kind of stiff, and they groan, and then they start jerking in like that. A tonic seizure is just a really quick stiffening, and then atonic just means that they just kind of fall and drop to the ground. And often these tend to run in families, okay? So the absent seizure, as I said, it's like a blank stare. They're unresponsive. It lasts for a few seconds. This particular kind of seizure, they're not confused after it's over. And it typically begins in childhood or adolescence. And I think I have a video of an absent seizure here.
Absent seizures are brief lapses in awareness that begin and end abruptly. This girl is having an absent seizure.
Sabrina, talk to me.
What? I'm fine.
I always tell my mother this. I'm fine.
In an absence seizure, generally the concept is that they're disconnected for a few moments. They're very likely to pick up exactly where they left off, but generally speaking, they do not know what is happening in that 3, 4, 5 second period of time.
This girl also has absence seizures, and you will see her have one as she's talking.
They take back that statement because he can be as heavy as ever,
Then there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Oh, pardon?
Sorry? So that's an absence seizure. It's fairly brief, as the video says. It usually lasts about 3 to 5 seconds. They are not confused afterwards. They may kind of like have some eye blinking or look kind of over to the side, but they're quite mild. But they may happen many, many, many times a day. And if we look at their brain waves, a lot of times we're seeing this brainwave pattern many, many, many times an hour. Although many of those times you can't see anything in the patient's expression, the brainwave activity may be going on and they're fine, but once that brainwave activity goes on for 10 seconds or so, then they kind of go into that blank staring spell. So we call that an absence seizure. A myoclonic seizure, this is a little muscle jerk type thing. This is one of my favorite videos.
I woke up this morning and I'm having my epileptic twitches, and so I'm taking a video of it because I want to know what it looks like. Because, whoa, did you see that?
So that was a gal who was having myoclonic seizure, just little muscle jerks. And again, on her brainwaves, if you're looking at her brainwaves, you would see that about 1 or 2 seconds before the muscle jerk happened, she would have that same brainwave activity that I showed you before. Okay. Now this is a convulsive seizure. This is a person who's actually going to have a convulsion, so I'll give you a warning up front. But again, the primary generalized seizure, kind of, the brainwaves would look similar at the beginning. Okay?
Or you can like carry it to the shirt.
We have a little miniature spirograph that we take in the car when we travel. You know what a spirograph is? It makes little designs. It's like a gear. You put your pencil in holes in it, and anyway, it makes all kinds of little designs. She'll be coming in.
So his arms kind of get stiff, and then they'll start jerking.
Hi.
And then that will go on for usually about 30 seconds to a minute, minute and a half. They might bite their tongue. They might have a hard time breathing while it's going on, so they might turn a little blue. But in the end, the seizure stops, and generally people do not have major injuries or complications even from that kind of a seizure. Now, what they might have is if they were standing up and fell over, they might hit their head or injure themselves that way. If someone was trying to hold them down because they're not really responsive, they can't really understand what's going on, they might actually injure themselves because someone's trying to restrain them while that jerking's going on. So people sometimes get injured that way. But the seizure itself generally is very difficult to look at. As a family member, it would seem like it's going on forever, even though it's only going on for about 30 seconds to 2 minutes. But in fact, people do okay afterwards. Is this microphone working? It sounds like it cut out. Okay. So in contrast to the primary generalized epilepsy where the brainwaves are, or the whole brain all at once, with a focal seizure, which starts in one spot in the brain, what we see is that the abnormal brainwave activity really comes from one area. So remember that each of these lines represents one of those wires that are glued to the person's head. And for simplicity, I like to color my left-sided lines blue and my right-sided lines red. So you can see here that you've got this activity that's going on over here, but it's really just in the red lines over here, and then the red lines over here. So this is just going on the right side of the person's head, the right side of the person's brain. So this is a focal seizure as opposed to a generalized seizure. So what do people do during focal seizures? Well, oftentimes they're a little confused. They're not really aware of what's going on. They may make funny movements and things like that. So here's a video of a young man who's having a partial complex seizure.
Complex partial seizures may begin abruptly. This man goes into a seizure as he's talking.
I had a whole summer with the job, and I was there.
They may still have their eyes open, they may be standing upright, they may even walk around the room, but they're not interacting appropriately with the people around them at that time.
I think I have another one. Here's a gentleman who's talking about his seizures. He's not having a seizure in this video, but he's talking about his seizures.
Just start rolling my left hand over and staring at it, and I play with my buttons. It's really weird when you got a t-shirt on that you're picking at your buttons, but that's one of the things I do.
Kevin? 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 Can you hear me? Can you hear me?
Complex partial seizures may create a variety of automatic movements or behaviors, such as this young woman is having. She cannot control these movements, nor is she aware of them. The movements of her hands are automatic. They look like deliberate movements, but they're not. They're part of the seizure. Her awareness of her surroundings is clouded.
So people kind of do these automatic movements. We actually call them automatisms. And you could see in this last video I just showed you, this girl walks up to the girl next to her and starts, playing with, doing something with her shirt. So you can imagine that if someone was having a seizure and they started doing, funny things to people around them, it can be quite alarming to the people around them. There was a newspaper story a couple years ago about someone who was having a seizure like this on the subway in New York, and he got arrested and was in jail for about 3 days because people thought that he was assaulting this person that he was touching, but it was just that he was having a seizure and doing one of these kind of funny things. So the way that we treat seizures, the way we treat epilepsy is primarily with medications. And so back in 1900, the very first seizure medicine was discovered, and that was phenobarbital. And then in around 1925, Dilantin came out, and then in 1950s there was Mysoline, and then in 1975 we had Tegretol. So all the way up until 1975, we still only had 4 medicines. And then since that time, there's really been a big boom, and there's been a lot of seizure medicines have come out since that time. So by the year 2000, which was, I moved here to Hawaii in 1998, so around that time, we were up to about 10 medicines. But as of today, we've got 22 medicines that are out on the market for treating epilepsy. So that's a lot more medicines. Now, unfortunately, it hasn't really made a huge difference in the percentage of people who are actually well controlled with medicines. So if we look at people with seizures, and so this is a study that was done in the United Kingdom, where they, because of socialized medicine, they have medical records of all the diagnosis and all the medicines that they were treated with and whatever. So it turns out that when someone got started on seizure medicines, almost half the time they were well controlled with just the very first medicine that was chosen. So out of all those 22 medicines, it turns out it really didn't matter which one of those medicines the doctor chose. Almost half the people it worked. So about half the people just have really easily controlled seizures, okay? And then if the first medicine didn't work, then they would try another one and a third one, and they would pick up another, in this case, 14%. But no matter how many medicines they chose, after that point, only another 3% of people got their seizures under control. So if you failed the first 2 or 3 medicines, the odds were really slim that you would get seizures under control with any other bunch of medicines or combinations of medicines that were tried. And so that left about a third, a little more than a third of people with really difficult to control epilepsy. The medicines just didn't work, no matter what medicines were tried. And so we call that medication refractory epilepsy. So where medicines didn't work, okay? Refractory means that it didn't respond to the medicines. And you might ask, well, why don't the medicines work? Well, I said, it didn't matter what medicine the doctor chose. almost half the time the first medicine worked. Well, it turns out that there are some medicines that actually don't work for some of the epilepsies. Remember how I showed you that some seizures start over the whole brain all at once, and some seizures just start in one spot? There are actually some of the medicines that we have that really don't work so well for the seizures that start over the whole brain all at once. But not every doctor actually knows that. Most neurologists do, but your general doctor may not know that. And so some of the most common medicines that we use, medicines like Tegretol and Neurontin and things like that, they just don't work for those type of seizures. So it may be that the doctor was just choosing the wrong kinds of medicine. It might be that it's the wrong diagnosis. There are actually funny spells that people have that can look like seizures, but they're really not seizures. They're something else entirely. Could be maybe someone's passing out because their blood pressure is low or because their heart rate is irregular or things like that. Or it may just be that there are some very difficult to treat underlying causes. So some people with epilepsy, and remember I showed you that MRI scan and I pointed out that very subtle abnormality, that turns out to be something that's very, very hard to control with medications. So sometimes it's just people have bad luck and they happen to have a cause of epilepsy that's very difficult to control with medications. There is a thing that we see very frequently called non-epileptic seizures, and I like to say that not everything that shakes is actually a seizure. So these are funny spells that people have that look like epileptic seizures, but in fact it's really a psychological reaction to stress or typically to some sort of deep psychological trauma. So we see this very frequently in people who've had histories of physical abuse or sexual abuse. We see it a lot in people who come back from the war, in our veterans. And so the VA actually sees a lot of these non-epileptic seizures, and it's really kind of a type of post-traumatic stress disorder or a symptom of post-traumatic stress disorder. And it may look very similar to the epileptic seizures. So here's a video of one of these non-epileptic seizures. This comes from YouTube. And actually, I'll tell you that if you search for seizures on YouTube, a lot of them turn out to be these non-epileptic seizures. Oop, I thought we were going to see that. Maybe we aren't going to see that video. It can look a lot like an epileptic seizure. So what do you do when medicines don't work? Well, the first thing I like to do is take a step back and think, gosh, do I have the right diagnosis? Are we really dealing with epilepsy? Is that the reason why the medicines aren't working? And the way that we figure that out is we do video EEG, where we have people come into the hospital and we glue all these EEG wires through their head, and we put them in a hospital bed, and we take away their medicines, and we make them stay up late at night, and we flash lights at them and make them hyperventilate and do the things that we can do to try and make them actually have one of these seizures, and then look at their brain waves. So one of the videos that I showed you, the one with the convulsion where the guy actually had the grand mal type seizure, if you think back to it, he was lying in a hospital bed and there were all these EEG wires glued to his head. So that's how we got some of these videos, okay? So we look at the brain waves and we look, okay, what kind of seizures are we dealing with? Are we dealing with epileptic seizures versus non-epileptic seizures? Is it really a heart irregularity that we're seeing instead of a brainwave irregularity? Are we dealing with the primary generalized or the focal type of seizures? That can, doing that test can help us figure that out. And then we need to kind of figure out, okay, are the medications the correct medications for that person's seizure type? Because different seizure types respond to different medications. And if the answer to both of those are yes, those are epileptic seizures and we were treating with the right seizure type, but they're still having seizures, then we might want to think about some other treatment options other than just with medications. And those might include a very special diet called a ketogenic diet. It's like a super strict Atkins diet. There's brain surgery as a treatment option if we can figure out exactly where the seizures are coming from and if it's a part in the brain that's safe to remove. And then there may be some investigational treatments. And then also there are some implanted, I'm not sure if I put it in here, but there are some implanted devices like a vagus nerve stimulator. And then there's kind of like a heart defibrillator that we put in for the brain that we put in the skull, and that's called a responsive nerve stimulator system. So we do have other treatment options if medicines don't work. Now, the final thing I'd like to leave you guys with tonight is some advice on what to do if you see somebody having a seizure. So, Here's a nice graphic that from the Epilepsy Foundation. And so for grand mal type seizures or the convulsion type seizures, if they're bumping their head on the ground, maybe put a shirt or a jacket or something under their head so they're not hitting their head on the hard ground. If they've got a tight tie. So this poster was made for the mainland. We don't wear a lot of ties around here. We don't walk around with very many jackets. But if they're wearing a tight tie, loosen it up. You can turn them on their side and then just wait for the seizure to end. Like I said, almost always it will end within 30 seconds to 2 minutes. Don't put anything in their mouth. So the old, myth was, put a wallet in their mouth or a spoon in their mouth or something like that. Don't do that. People cannot swallow their tongue. People worry, he's going to swallow his tongue, he's going to choke on his tongue. It doesn't happen. They might bite their tongue, they might bleed from their tongue, but their tongue will heal up. But if you put something in their mouth and they accidentally swallow it or that can get stuck in their throat and block their breathing. So we don't want to put any foreign body in their mouth. And definitely don't put your finger or your thumb in their mouth because they might bite your finger or your thumb very hard. Because remember, they are not in control of their muscles during this time, so they may have very strong muscle contractions, including their jaw muscles. You don't really want anything in their mouth. They may be looking, or they may have like one of these medic alert bracelets or necklaces or something like that says they have seizures. And so if they do have seizures, you don't have to call an ambulance. They don't have to go to the emergency room if they're someone who's known to have epilepsy. If it's someone where it's their first ever seizure, then we got to figure out why they're having their seizure. So they should go to the emergency room. But if it's someone that has epilepsy and they've had seizures before, they don't need to go to the emergency room unless they really injure themselves or the seizure's just not stopping or things like that. And then as the seizure ends, talk very softly and gently to them. You don't want to really crowd them. They're in a very confused state. So if you think about like if you're sleeping and you're in a really deep sleep and someone like shakes you awake right in that first moment when you're waking up, you're really confused. You don't know what's going on. You're kind of like shocked. And that's kind of like what it's like to be coming out of a seizure. So if you've got someone who's in your face and trying to hold you down and trying to restrain you, they're going to fight that off, right? So they might strike out, they might lash out and hit you. And it's not because they're being jerks, it's because they're confused and they think it feels to them like you are trying to, constrain them or do something bad to them, okay? And don't hold them down. Remember I said with those muscle movements, they can be very strong, and if you're trying to restrain someone, we've had people who've dislocated their shoulders and had other injuries from people trying to hold them down. Now for the partial complex type of seizure, the one that I was showing where the video of the person kind of smacking their lips or doing this with their shirt or reaching out and touching other people, it can be hard to kind of recognize that. But if you see someone with a blank stare on their face or the chewing movements or the fumbling movements or they're wandering around aimlessly or they really seem very confused, then don't grab them, don't try and restrain them. Again, you want to make sure they're not going to walk out into the street into heavy traffic, but generally you don't want to try and hold on to them. Maybe let others know, they're having a seizure, they'll be okay. Block the hazards, so again, don't let them kind of stumble down the stairs or walk into traffic. Talk calmly to them. Keep track of the time, because if it goes on for too long, then you would want to call an ambulance. And then wait until the seizure's over. Give them a few minutes to recover, and they should be fine. Okay? So do not panic or walk away. Don't try and hold down or restrain them. Don't put anything in their mouth. Don't try and move them unless they're in danger. Obviously, if they're about to walk into the street, you want to move them. And according to the Epilepsy Foundation, don't give them anything to eat until after they're fully recovered. Do you need to call an ambulance? Well, if it's their first ever seizure, okay, it's your family member and you know that they don't have a history of epilepsy, yes, I would call an ambulance, figure out why it is that they're having a seizure, because it could be, that the seizure is a symptom of something bad going on and you want to figure that out. Most seizures stop within 30 seconds to 2 minutes. So if it's going on for more than 5 minutes, all right, that's an unusual seizure. At that point, I would call an ambulance and get the process rolling to get them into the emergency room. You can call an ambulance if the seizures happen one right after another, especially if they don't wake up in between, okay? Because that can happen, but it's unusual. So if that is happening, that's a little on the unusual side, and you probably ought to call an ambulance for that. Definitely call an ambulance if the person's injured and they've got blood, coming from their head because they've bonked their head really bad, or if you think for other reasons that they really need urgent medical attention, then definitely go ahead and call an ambulance. But for 95% of the time, people don't need to go to the emergency room. They don't need to call an ambulance. They end up going to the emergency room. They sit around. By the time they get there, they're woken up. They're fine, and then they just end up getting a $500 ambulance bill and then a $1,000 emergency room bill. And so again, if someone has known epilepsy, they really don't need to go to the emergency room. So in summary, epilepsy and seizures are very common. 1 in 26 people will develop epilepsy or be given a diagnosis of epilepsy at some point in their life. So that's actually a very large number. There are different kinds of seizures. We have a lot of different treatment options. There are 22 different medicines out on the market for epilepsy, and then there are other treatment options, including brain surgery and a special diet and implanted devices. An excellent resource is the Epilepsy Foundation. Their office is down at Ward Warehouse, although that building is going to be turned into a big condo, from what I understand. So I'm not sure how long they'll be at that place, but you can look them up on the internet. The Epilepsy Foundation of Hawaii is the local branch, and the Epilepsy Foundation of America is the main branch. And again, I do want to remind you that on Saturday, November 12th, from 8:30 to 3:30, there will be a lot more talks about epilepsy right here in this very auditorium. So on that note, I'm going to turn it over to you guys to ask questions that you might have about seizures and epilepsy.
If you have any questions, please raise your hand and someone with a microphone will come down.
Everybody hear me? Yeah.
There we go.
Talk to us about epileptic.
Okay. The question was epileptic medications and pregnancy. So thank you for that question. It's an excellent question. People with women who are pregnant who have epilepsy are at a higher risk of having birth defects in the baby. Now, it's not 100% clear exactly how much of that increase is due to exposure to the seizure medicines and how much of that increase is just due to the fact that epilepsy is being caused by something which might be genetic, or there may be something about having seizures during the pregnancy itself that in itself slightly increases the risk of birth defects. But the typical, a woman without any health problems who gets pregnant, there's about a 1.5% to 2% of those babies will get birth defects. In women with epilepsy, that number is closer to about 3%. So there is a slight increased risk in birth defects. Now, having said that, there's a pregnancy registry where if a woman becomes pregnant, when she comes to my office, I give her a card that says, call this pregnancy registry. They're keeping track of birth defects for women who are on seizure medicines. And so we actually have quite a bit of information about a number of our seizure medicines. And we know that there are 2 medicines that particularly have a high risk of causing birth defects. And those are phenobarbital and valproic acid, which is also known as Depakote. We know that those 2 seizure medicines, if a woman is pregnant on those, the risk of birth defects is closer to about 8 or 9% instead of 2 to 3%. Okay. There's another medicine called Topamax or topiramate, where there's a slight increased risk, about a 1 to 1.5% increased risk of a fetal defect called cleft lip and cleft palate. Now, the nice thing about, I shouldn't say the nice thing, but the somewhat reassuring thing about that particular problem is that it's usually correctable by surgery. Not always, but usually. And so if a woman is pregnant and their baby has that particular defect, birth defect, that can often be fixed by surgical treatment. The other seizure medicines, most of them do not dramatically increase. Actually, none of them that we know of dramatically increases the risk of birth defects other than those that I just mentioned. There are some that we just don't know enough about because not enough women have been pregnant on that particular medicine. but we know about medicines like Dilantin and Tegretol and Lamictal and Keppra and zonisamide. So there's a lot of the seizure medicines that we actually know quite a bit about, and reassuringly, those don't seem to have a really significant increase in the risk of birth defects. Did that answer your question, or was there any other aspect of that that you wanted me to talk about?
Well, my mother had epilepsy when she got pregnant with me. My mother had epilepsy when she got pregnant with me. I think it was a miracle. I think it was a miracle that I was born normal. Of course, I think later on she tried to change that.
So I would say it's not a miracle at all. As I said, for the vast majority of women with epilepsy who are on seizure medicines, the risk, for almost all the seizure medicines other than those 3 that we talked about, none of which had been discovered back when your mom was pregnant with you. Most seizure medicines do not cause birth defects. So I don't think it was a miracle at all. I think women with epilepsy can get pregnant and have kids and lead completely normal lives. Okay. I know there was going to be a question over here.
Is there a question down here?
Yeah, right over here.
I would like to ask you to talk about temporal epilepsy.
About what? What kind of epilepsy?
Temporal epilepsy.
Temporal lobe epilepsy.
And the possible connection with serious migraine headaches.
Okay.
And the treatment.
So temporal lobe is a part of the brain. So I'm way far away from you guys, but if you put your hand up like this and kind of make a fist, this part of my thumb, it kind of looks like your brain, right? It kind of looks like your brain. And this part of my thumb is the temporal lobe. And so different parts of the brain are more or less likely to have seizures, and the temporal lobe is the part of the brain that is most likely to have seizures. So it's the most common type of seizures. And so, for instance, the videos that I showed you of people with smacking their lips and picking at their clothes and things like that, those are very typical for temporal lobe seizures. Temporal lobe epilepsy just refers to the part of the brain where the seizures come from, and it's the most common type of epilepsy where we can figure out where seizures are coming from. Okay. Now, in terms of the relationship with migraine, there's been some thoughts over the years about the relationship, but nobody really knows exactly what the relationship is. Certainly, some people with seizures will have a headache after the seizure, and the headache sure sounds like a migraine in the terms of the type of headache. There are some people who say, well, my seizures are started by a migraine, I get a migraine, and then when I'm into the migraine, then I have seizure. But those are what we would call anecdotal stories. Some people, it happens to some people, and they'll talk about it, but it's never really been studied well enough to actually show a definite correlation, and we certainly don't know from a physiologic or a chemical basis why that connection would be there. But I have certainly had many patients who have talked about, having seizures and migraines, and the most common connection is that they get a migraine after the seizure is over.
In the 80s, I suffered from migraine headaches. I'm a neurologist, happened to be, and so we were just curious how the EEG looks like when I have this peak of my migraine. And it turned out that the EEG was a symmetric synchron Gronmal type EEG, and this was consistent. We were laughing. There was no treatment really, so just tried this and that. But this was an interesting thing, and at that time, I would not have imagined. I mean, nobody would have thought of the connection that migraine and the therapies, the Lamictal, is effective.
Yeah. So some of our seizure medicines are actually very effective migraine medicines, as you probably know. So medicines like topiramate, Divalproex, which is Depakote, Neurontin. Some of those seizure medicines are actually very good at preventing migraines as well. Now, I have myself never seen the epileptiform discharges on EEG while someone's having a migraine. What has been described in other literature is kind of what's known as spreading depression, which is not, doesn't show that. But that's very interesting that that you've got that experience in that EEG. Okay.
Other questions?
Any other questions? I think.
Oh, right here.
Oh, thank you. Okay. Yeah. My question is, it's in regarding women and men. I know that women usually have a menstrual cycle, and during that time, isn't it true that our body systems are a little bit more elevated or something, so that therefore we may have a occurrence of maybe possibly more seizure activity during the time of your menstrual cycle, and then it could be like diagnosed, I heard, as catamenial?
Right. Yeah, so catamenial epilepsy refers to a cycle where women have seizures that are timed to their menstrual cycle. And so, like migraine, there are some women where their seizures are very closely tied to their menstrual cycle. So some women will say, oh, I have my seizure, I always have my seizure right when my menstrual cycle starts, right when the bleeding starts. Some women will say, oh, it's at the end of my menses. Some women will say, oh, it's when I ovulate, which is halfway in between the menses. And so different women might have seizures at different times. And the theory is that it has to do with the fluctuating hormone levels, because the hormone levels really go through very dramatic shifts during the woman's menstrual cycle. Now, unfortunately, so it might seem like, oh, well, we'll just, the OBGYNs know how to give you medicine to stop you from having periods, right? So the kind of the obvious thinking as well, we'll just give you medicine so you don't have periods anymore and the seizures will go away. But the reality is that doesn't really happen. The periods get stopped, the menstrual cycles get stopped, but the seizures continue. And in my experience, they tend to just lose the predictability. So you might have had 3 or 4 seizures right around your menstrual cycle, and now every month you still have 3 or 4 cycles, but now they're kind of randomly distributed. So they're not, at least they're not predictable. That has been what I've seen with most women. Now, occasionally, going on the hormone treatment actually will stop the seizures or dramatically improve the seizures, but I would say that that's relatively infrequent. Doesn't mean I won't try it if I have a patient who has a very close relationship between their menstrual cycle and their seizures. Even if I have a woman who doesn't, but they have bad epilepsy, oftentimes I will recommend that they try progesterone treatment. Not estrogen. Estrogen tends to probably make seizures a little worse, but progesterone as a treatment. And occasionally, it works or it's helpful. More times than not, though, it turns out to be a disappointment, because it seems like it should work, but it really ends up not working very well. So are there specific medications at times that you can take? So sometimes we'll have people go up to a higher dose. We'll say, okay, take 1 pill twice a day most of the time, and then that your seizures usually start the day after your menstrual cycle, your menses start. So as soon as you start to have menstrual bleeding, go up to 2 pills twice a day, right? So we might just tell them to increase their usual dose of medicines. There are also medicines that we'll sometimes use to try and turn off a flurry of seizures. So medicines in the Valium family, and that includes Ativan, which is lorazepam, or clonazepam, Klonopin, or even Valium, which is diazepam. So sometimes we'll use that when someone's having a bunch of seizures, and so sometimes we'll say to women with the menstrual cycle seizures, okay, when you're getting near the day where your cycle is going to start taking one of these pills 2 or 3 times a day, and do that through your cycle, and then when your cycle's over, you can stop taking that medicine. So either going up to higher doses of the regular medicines or adding in another kind of preventive medicine just during that week. Yeah. So the question is a diuretic helpful? Not in my experience. It's definitely, it's not what I would usually try.
Okay, we have a question over here.
For someone with grand mal seizures, what are the percentages of the chances of them growing out of it? And secondly, what is it about the ketonic diet that prevents the seizures? And are there any other types of diets? That
Sure. Excellent questions. So the first question is, what are the chances that someone with grand mal type of seizure is going to grow out of it? And the answer to that really is what kind of, why are they having it? How old are they? How old were they when they started? And things like that. So there are certainly some epilepsy syndromes, usually that start in children or adolescents, that people will grow out of, okay? But if someone's had seizures, they're through with all of their, through childhood, and now they're in their, mid-20s and they're still having it, they're probably not going to grow out of it, okay? So that's just probably not going to happen. There are some people where seizures just stop, and we don't know why. There's one patient I have who I fondly think of, and she used to just, every time I see her, she's still having seizures every other day, averaging about 15 seizures a month, okay? And one day she came in and said, okay, how many seizures, are you having these days? She's like, oh, I haven't had any. And I'm like, what do you mean you haven't had any? You always have seizures. No, I haven't had any for a couple of months. And now it's like 12 or 13 years later, and she still hasn't had any. We never changed the medicines. She's on the same medicines that we have always used. Nothing was different. It's just one day they stopped. Now, that's a rare story. I don't want you to think that that's likely to happen, but sometimes it happens. Sometimes we find the right medicine for people. So there's a couple of newer medicines out on the market that I've been really happy that a couple patients I've put them on, they come in and I see them, and I'm expecting them to say, I've had 5 seizures a month since the last time I saw you. Oh no, since you started that new medicine, I haven't had any seizures. Or I used to have 10 or 15 seizures a month, and now I've only had 2 in the last 6 months. So new medicines, even though the odds are low, remember I showed you earlier with that pie chart, the odds are pretty low that new medicines are going to help. It's not zero. And so if there aren't other treatment options like surgery, then we continue to try different medicines, and hopefully we'll hit a grand slam one of these days. Now your other question was, how does the ketogenic diet work? I wish I knew. Nobody really knows how the ketogenic diet works. The ketogenic diet is a special diet that is extremely low in carbohydrates, almost 0 carbohydrates. So it's like the Atkins diet, but much, much, much stricter than the Atkins diet. And the body actually starts producing what are called ketones, which is, you can test that in the urine to see if they're in the urine. And we think that it's something about being in that ketotic state. The ketotic means making ketones. We think that there's something about that changes the brain's metabolism. We really don't know how it works. There are other diets that are kind of similar. So for instance, here at Queens, we do offer the what's called the modified Atkins diet. So you may all be familiar with the Atkins diet. It was very popular 15 years ago. So the modified Atkins is actually a strict Atkins diet. It's you would think modified Atkins, so it must be a little bit less strict, but it's actually a little more strict than the Atkins, but not as strict as the ketogenic diet. And again, it's a very low carbohydrate diet. There's not as much data on how well it works as the ketogenic diet, but there is some data that would suggest that it does work for some people. And so we have a dietitian that we work with here, and my nurse practitioner who was sitting out at manning one of the tables out there when you were coming in. She runs our ketogenic diet. Our modified Atkins diet program. There's also something called a South Beach diet, and there's a glycemic index diet, and our dietitians, we don't really use that particular diet, but those are diets you can do on your own. You don't need to go to a dietitian and have special care. Those diets are things you can do on your own, and they also seem to confer some improvement in seizure frequency. Now, I would not recommend that for people who have well-controlled epilepsy. Really, we're talking about these major lifestyle changes in people where the medicines aren't working and the seizures are really affecting quality of life, because you really have to stick to these diets. There are stories of people, kids. Ketogenic diet is mostly used in kids. So there's stories of the kids who are on the ketogenic diet, and they got like a children's Flintstone vitamin, by accident, which has sugar in it, and all of a sudden, boom, they started having seizures again because there's enough sugar in that, in that vitamin to take them out of that ketotic state. Okay.
Okay, we have time for one more question.
There's one up here.
Well, sir, okay, you mentioned that the person is on the medication and then they're amazed that they're not having any more seizures. So what I'm familiar with is taking the medicine every time, every day, and maintaining it and being very good about it. So how would you know that you're not having seizures if you're just constantly in the medicine? Do you get weaned off of it and then no medicine and then you come back and say no seizures?
Right. So that's a good question. I think, so I'm going to rephrase it and interrupt me if you think I'm rephrasing it incorrectly. You're on seizure medicines, it's doing its good job, you're not having seizures, and then at some point, how do you figure out if you still need to be on the medicine? Is that?
Yes.
Okay, so that's an excellent question, and thank you for bringing that up. So typically, what we will do is we'll say we want someone to be seizure-free for 2 years. And once they're seizure-free for 2 years, then I'll have a discussion with the person about whether or not to take a chance to come off medicines. Now, even if you've been seizure-free for 2 years, there's about a 30% of people, if you stop the medicines, will have seizures come back, okay? And so if you have seizures come back, in the state of Hawaii, you can't drive for 6 months, right? So I didn't talk about driving, but in every state restricts driving for people with seizures. In the state of Hawaii, it's a 6-month restriction. If you have a seizure, you can't drive for 6 months. Every time you have a seizure, that 6-month clock starts again. So if you've been seizure-free for 2 years and you're doing great and you're driving and you've got a job and life is hunky-dory, and I take you off your seizure medicine and now you have a seizure, you can't drive for 6 months. Now for some people, they might say, that's not a big deal. I work near where I live, I can walk to work, or I live right next to the bus stop, I can take the bus, or I can get a ride in with a friend or whatever. It's not a big deal. Driving's not a big deal to me. And in that case, and they might say, and I really don't like taking medicines. It really makes me, feel bad, or my body's a temple, and I feel like every time I'm taking medicine, I'm poisoning my body, and I really don't want to be on medicine. And to that person, I would say, great, let's do a brainwave EEG test. If it looks okay, it's not a guarantee you won't have seizures, but it's kind of reassuring, and then we'll take you off the medicine, not just stop it cold turkey, but we'll probably take a couple weeks to a couple months, get you off the medicine, and then we'll cross our fingers. We'll also get a brainwave test when you're off the medicine to see if that shows anything, but then we cross our fingers, and that's all we can do. We cross our fingers and we wait, and hopefully you don't have any seizures. And if you don't have seizures, then that's great. You don't need to be on medicines anymore. And if you do have seizures, then we put you back on the medicine. Now, you might say, gosh, I have to drive for my job, or driving is super important for me for my sense of freedom and independence, so I don't want to take that risk. And to that person, I would say, that sounds fine. Stay on the medicine. There's no reason why we have to stop the medicine. There are some potential long-term side effects of medicines, and we should be aware of those and maybe test for osteoporosis and think about some things like that. But for the most part, that's great. If you want to stay on the medicine and don't want to risk it, then there's generally not a problem staying on the medicine.
Thank you very much. I'm glad that you ran into the portion in regards to driving and for work. Is the Equal Employment Opportunity Commission, the ADA, are they aware of any of these? Are they educated in any of these things here? Because what I need to know is, okay, let's say we're on a medication. You mentioned all these medicines, and some of them would be narcotic and non-narcotic, correct? And so if a person wanted to continue working and you come up with a 1% chance of having a seizure, is that a general number that they use?
Yeah, so different employers will have different rules, and for the most part, the rules should reflect what the safety considerations of that job, okay? So for instance, there are some jobs where if you have a seizure and you're on medicines, you just can't have that job, period. So being a heavy truck driver or heavy equipment operator, where you're required to have a commercial driver's license, a CDL, there are federal guidelines and you're just out. You're just not going to be able to get a CDL. Airplane pilot, the guys who operate the big cranes that unload the ships, their guidelines say that they essentially have to have a CDL or have the same guidelines as a CDL. So there are some jobs that you're just not going to be able to have that job. There are other jobs where maybe driving is a part of that job, and as long as you've made your 6 months, then I would say, okay, you're okay to go back to driving. And if the job is still saying, no, we're not going to let you drive, unless they have a really good reason for it, then I think the Americans with Disability Act would kick in, and you'd have a good argument to say, no, you got to let me, go back and do this job. And then there are other jobs where, I tell people, even if you have seizures, you can do that job, right? As long as you're not having, seizures 3 times a week. If you have a seizure once or twice a month, there's no reason why you can't be at a job that's mostly a desk job where you're not going to hurt anybody or you're not going to hurt yourself. You might not want to be working at Walmart where you're climbing up to the 12-foot ladders to restock the top shelves, but there's no reason why you can't be working at another job where you're stocking the lower shelves. So the job, whether or not you're allowed to do your job if you have epilepsy, is really dependent on the duties that are defined in that job. Now, the Americans with Disability Act also says that the employer, unless they're like less than 50 employees total, so small employers are exempt, but big employers, they have to find you, they have to make what's called reasonable accommodations, which generally means that they can either do job modifications, so modify your duties, or find a different job for you. Now, they don't have to pay you the same wage. So maybe you were a truck driver delivering Coca-Cola, and now you can't do that, but you can be a janitor, right? Well, a janitor doesn't pay as much as the truck driver. They don't have to pay you the wage of the truck driver. They just have to offer you a job that you can do within your limitations. So I don't know if that answered your question.
Well, you're kind of in the general area. Let's go specifically with military. With further questions into military, the military is not subject to the ADA or the EEOC.
Right.
Okay. Now we're dealing with a VA system, and if you're going with a 1% chance of a person having it, if the VA doctor is asked by the employer, by the military people, so what's the chances? Give me a percentage that this person can have a seizure.
And every case is going to be different, yes. So I can't answer that for you.
I haven't seen yet less than 1.
Well, everybody in the world has a 10% chance of having a seizure at some point in their life.
So how could they be biased towards an employment for a person to return back to full duty?
Okay, so the military is a different story. You're carrying a weapon, right? Other people are relying on you. If you're deployed and you're in a deployed situation and you're in a firefight, right, and you have a seizure, then other people are at risk. So just like a commercial driver's license where there is a heightened risk of you or someone else being injured with a seizure, the military also kind of takes that role. And I do not disagree with them. I think that they are correct in having those rules. Now, different branches of the military, to my understanding, have slightly different rules. So, for instance, my understanding is that in the Army, if you are well controlled on medications, not having any seizures, you can stay in the Army, but you're not deployable. But if you're not deployable, that limits your ability to be promoted and things like that. So this is probably a discussion that's a little outside the scope of what we're talking about today, but different the military is different than the most civilian jobs.
Well, okay, so now you cannot.
Wait, I'm sorry. I'm going to cut you off because we're out of time, and this is something that you and I can talk about. But I want to thank everybody else. I want to thank everybody, including you. I want to thank everybody for coming.